So today we're talking about joints, aka articulations. That's where we come up with the term articular surface when we're speaking of a bone, like we were talking about last time. Usually an articular, not usually, always an articular surface will be where two bones meet, and that's basically going to be what a joint is. It's the meeting of two bones. Sometimes it's movable, sometimes it's immovable. But the big thing they're going to be there for is to give the skeleton stability, to hold the skeleton together, and so you can move, because as you know, bones don't just bend. So when we classify our joints, they can be classified based on the type of material they are made out of or the movement they have. So if we have, they can be immovable, they could be slightly movable, or they could be freely movable. So a good example of a immovable joint could be like the sutures in your skull. Those guys, they're not going to move at all. When I think of a slightly movable joint, I think of your intervertebral discs. They're these cushion pads between your vertebrae, and they allow for just a little bit of flexion, extension, and they let you move a little bit. And then when you think of a joint in general, most people are thinking of a diarthrotic joint or diarthrosis. A diarthrosis is your joints that move freely. So like your shoulder, your elbow, many of the joints in your hand, those guys are all going to be freely movable joints. Sometimes they're one directional, sometimes they're in a bunch of directions, but they move freely in the directions they can move. The next one is, how are these guys going to be held together? So they can be held together by fibrous cartilage. Alright, so they could be a nice cushion. They could be held tightly together. They could be cartilaginous, or they could be synovial. When you think synovial, that's usually going to be our diarthrotic joints. That'll be these. So our synovial joints, when I think of a diarthrotic joint, I usually connect it right along here with the diarthrosis. Okay, because these are both going to be important for freely movable joints. Okay, so with our fibrous joints, these guys are going to be held together by dense fibrous connective tissue. There's no cavity, all right? So when I think of this, the one that always pops into my head first is a gomphosis. This is your peg in socket. This is the way your teeth are held into place. So your tooth, it does not move very much. It is stuck in there, and it has like a ligament almost just holding it right in place. So let's look at these. First one are our sutures. So your sutures are going to be held together by this dense fibrous connective tissue, almost if you were to picture a ligament, but it's not very long. It is just like a layer of glue. When I think of this, I think of taking two bones that fit perfectly together and connecting them together with super glue. That is what this dense fibrous connective tissue is like. They're nice because when you're first born, you remember what we called these? We called these fontanelles. So it started off as like a nice pattern for the bone to grow over, and now as you age, it's a nice strong connective bond. Another one is going to be called a syndesmosis. This is going to be found the most, when I think of this, I think of your elbow with your ulna and your radius, and I think of your fibula and tibia. So those are going to be the ones that I think of. These are going to be slightly movable, but some of them are going to be immovable at the same time too. A lot of times when you find these, there will be a diarthrosis, a diarthrotic joint, or an interosseous joint between them. So, but these guys, they're going to form a very tight connection holding one bone to the next. And the last one out of these fibrous joints, this is going to be a gomphosis. Like I said, that is called a peg in socket. So the way your tooth is going to fit into your mandible or your maxilla. When I think of this, the way it's going to work is if you were to take your tooth and the tooth is a peg, the mandible or the maxilla is a socket, take that tooth, dip it in super glue, now drop it into the socket. That super glue would represent the ligament. So it is going to have a nice strong bond, and it's going to be held from all angles, not just the base of the tooth. Okay, next ones are cartilaginous joints. So these are just going to be two joints held together by cartilage. Okay, there's going to be two types, synchondroses and symphysis. Alright, so when I think of synchondroses, I think of your I think of your ribs. All right. So do I have a better picture of the ribs? No. So think of your costal cartilage. The way that the ribs are going to be held to the sternum with that costal cartilage. That is a great example of a synchondrosis. Another example could be your epiphyseal plate, your growth plate. That's going to be a temporary synchondrosis. Next ones are symphysis. So wouldn't it make sense? The best example of a symphysis type of joint is your pubic symphysis. So that's going to have almost like a spongy type of thing. It'll be glued together very tight, but it'll act almost like a shock absorber. And the best example of shock absorbers for these types of joints in your body are going to be your intervertebral discs. Okay, now our last ones, our synovial joints, are going to be freely movable. They're going to have some defining features or distinguishing features about them. First, they have this stuff called hyaline cartilage. Hyaline cartilage is going to provide a strong network. If you look back and think, we talked about hyaline cartilage before, how it helped build your nose, or it could be used to make your tracheal, your trachea and your bronchial tree. It gives you a nice strong structure. Okay. Next one's going to be your synovial or joint cavity. That'll be the small open space. So in all of our freely movable joints, there's going to be an open space in between them, or a potential space. Next one's going to be a joint capsule. So most of our joints, if you were to strip them down and get all the muscle, all of our joints, if you strip them down and get all the muscle passing over them and get all the ligaments and all the stuff and capsule ripped off from around them, they're actually going to be much smaller. They're not going to be as large as they appear as they're covered by your skin and everything else. And the reason why is they're going to have this protective capsule there to protect it from shear in all different directions. It will be strongest in the directions that that joint moves in, but it will also be there to just kind of hold it in place. The next stuff is called our synovial fluid. We will find the synovial fluid inside the synovial cavity. When I think of this synovial fluid, this is like the oil for the inside of your joints. It has a egg white type of consistency, and that works well because egg whites are filled with nutrition. So these are going to be there to lubricate and nourish the joint cartilage or the articular cartilage. Each time you move your joint, you release synovial fluid. Okay, so when I think of a joint, I think of two bones coming together. They have a layer of sponge on the surface of the bone, and then there's a layer of saran wrap wrapped over that sponge. That sponge is going to be soaked up with oil. We'll call it synovial fluid. We poke holes inside of that saran wrap, and now when we put oil on saran wrap, I mean that stuff is like, it's got almost zero friction. So imagine two pieces of saran wrap with oil in between them rubbing against each other. That'll be very little friction, and that's good for our joints because we don't want to have to use a lot of energy for the joints to move. When you start getting arthritis, what happens is that sponge starts to dry up, and and the saran wrap layer there starts to break down, and you get little pieces of bone poking through. So as we get the pieces of bone breaking through, they're going to start ripping up the other side of the joint. So we have a whole huge problem there. Anyways, our distinguishing features, we said articular cartilage, the joint cavity, the capsule, the synovial fluid, which is like oil. And then there's going to be reinforcing ligaments. We can have capsular ligaments, which would be inside of the joint itself. We can have extra capsular ligaments. So capsular ligament, we have extra capsular ligaments, which will be outside of the joint capsule. And then we have intracapsular ligaments. These are going to be the deepest ones. Okay, so if you think of intra, that's inside, capsular would be the middle layer, and extracapsular would be the outermost layer. And then the last one, we're going to have a rich nerve and blood supply. Okay, so we're going to need a rich blood supply and nerve supply. Why? First off, we're going to want to detect pain. Pain is not bad. The reason why your body has pain receptors is so you know that you're damaging your tissue. That's your body's way of saying, hey dummy, whatever you're doing is hurting me, stop it. This is not good, you're going to damage your tissue. That's all they are. They're called, so they're just there as basically receptors to say damage is occurring. Then capillary beds. So we're going to need a rich network of capillary beds so we can take take fluid from the blood and make synovial fluid. Once again, that is going to be the oil to line our joints, and it's also going to be there to nourish the joint. No synovial fluid, no nourishment. And with your joints, I always say use it or lose it. The more you use the joint, the more oil you're squirting in there. So picture each time you move, you have a little oil can, you're squirting a little synovial fluid in there. If you're not moving, you're not squirting any synovial fluid in there. That means that the tissue is not getting any nourishment. That means the tissue is going to start to break down. So here's an example of our synovial joint. So let's check this out. Let me get a little pointer here. So here's our joint cavity, or our potential space. All right. Here's our synovial membrane. This shows our articular or hyaline cartilage right here. The articular or hyaline cartilage is going to be very good for a shock absorber. Next out, we're going to have our ligament holding one bone to the next. Okay, and then inside of that, so this would be extracapsular, this ligament. This hyaline cartilage here, we could call, this synovial membrane here, this green one, we could call that intracapsular. And then this layer right here that I have the pointer at, I'm just going to put some dots on it. That would be the joint capsule itself. So that's the fibrous capsule. Okay, so with our synovial joints, we will want them to be friction free. That's why we have the synovial fluid. There's going to be other stuff that we're going to have to decrease tension of the muscles, because when we have joints, we're going to have muscles and tendons and ligaments, not muscles. We'll have tendons of muscles, and we'll have ligaments crossing these joints. Why? Excuse me. As your muscles contract, they pull the tendons closer, or they shorten, and that's going to move the joint. So if we have a bunch of layers of tendons laying on each other, we don't want them rubbing on each other all the time. If those are rubbing on each other, if we take two pieces of rope and we have them rubbing on each other, what's going to happen? Over time, they're going to break down. So our body has these things called tendon sheaths and bursae. What the tendon sheaths and bursae are is they're going to be these little layers of protective material. I would almost picture it as putting down like a little piece of rubber that is well lubricated. So if I have the two pieces of rope rubbing against each other, they won't break down. So let's look at it at the next slide. Here's the ligament, or here's a fibrous capsule, here's a tendon sheath. If these guys were rubbing on each other all the time, they're like two pieces of rough rope. They're going to break down over time. So what you have is an option. You can either have a tendon sheath wrapped around it, which will be lubricated, and it will soften and make these guys freely pass over one another so they don't break each other down. Or you can have a bursa. A bursa is going to be like a little pad, but at the same time it's going to reduce the friction between the two ligaments or tendons or capsular stuff. Okay, so stabilizing factors with our synovial joints. Since these guys are freely movable, we're going to need to keep them stable so they don't just fall apart like your shoulder. There's a lot of mobility there, but we need to be able to protect it so your arm doesn't fall off and you don't hurt your shoulder. If you think of when people hurt their joints a lot, one of the common ones is your shoulder. Why? Since it has all this motion, it's going to lack stability, such as other joints that other joints will have. So how are most joints going to get their stability? They'll have the shape of the articular surface, or where the two bones meet, will help a little bit. It'll make it so they fit nicely together. Ligaments, the number and the location, okay? If we have a lot of ligaments passing over a joint, they can give it a good amount of support. But usually the amount of support from the ligaments, that's just to stop it from moving outside of its normal range of motion. And then the most important thing that we're going to have for our joints is going to be our muscles. So we're going to have muscle tendons passing from one side of the joint to the next side of the joint. So with our elbow, we'll have muscle tendon passing from our humerus into our radius or ulna. That's going to be very important because those are going to be there and they're going to be semi-taut. They're going to be semi-contracted at all times. Why? To protect your elbow so you don't hyperextend or hurt it. So with our muscle attachments, we're going to have origins and insertion. The origin is going to be the immovable bone, and the insertion is going to be the movable bone. Think of it this way. Some of my brachialis muscle goes from my humerus into my ulna. When I contract, my ulna moves, my humerus stays still. Okay? So that is going to be the rule of thumb. Typically, the origin is going to be superior or medial. And typically the insertion will be inferior or lateral. It's not always the case. So the true definition of origin and insertion of a muscle will be the immovable part versus the movable part. But typically, superior is going to be origin, inferior is insertion, and medial is origin, lateral is insertion. Muscle contraction, like we said, causes the insertion to move towards the origin. So when I contract my brachialis, it pulls my forearm towards my humerus. The movements that you can have, they can be along different planes. They could be our transverse, frontal, or sagittal planes. Okay, with our joints, they're going to have different types of motion. They can be non-axial, which means they'll slip around. They'll just kind of shear about one another. They can be uniaxial, like your elbow. It's just going to go straight up, straight down. They can be biaxial, so they can move up, down, or left and right. A good example of those could be our joints in our spine. Or they could be multiaxial. They can move in all directions. When I think of a multiaxial joint, I am thinking of my ball and socket joints. I am thinking mostly of my shoulders and my hips. So there is a table, number 8.2. It's going to have joint names, the bones, their classifications, their functional classifications, and the movements they allow. I want you to check that out, and I want you to have a good idea of which joints do what and how they're going to work. So with our synovial joints, we can have our gliding movements, our angular movements, our rotation, or our special movements. So flexion, if I was going to flex my biceps or my forearm, I would be bringing my forearm closer to my biceps. If I was to extend it, I would be bringing my forearm away from my humerus. If I wanted to hyperextend it, I would try to move it past its normal resting position. Abduction, adduction, or abduction and adduction. I just say abduction and adduction so you know which one I'm saying, and it's easier to hear. Abduction is moving a body part away from midline. Adduction is moving a body part towards midline. So if a child or somebody is abducted, they are taken away from where they're supposed to be. So abduction is moving away from midline, and adduction, like I said once again, is moving towards midline. And circumduction is making a circle. With rotation, that is going to be rotating about a plane. So you would be just like turning your head from side to side. That would be rotation. And there are special movements. So we have supination, pronation. When I think supination, I think of the hand and I say soup please. And the reason why I say soup please is I have my hand right now standing up by my shoulder as if I was carrying a tray and I was a waiter. So I say soup please. Okay? Supination is when your palmar surface of your hand is up. Pronation is when your palmar surface of your hand is facing down. We have dorsiflexion or plantar flexion. The dorsum of your foot is the top of your foot. So if you lift your foot off of the ground, if you're staying up and you try to lift your toes off of the ground, that is considered dorsiflexion. Plantar flexion, put the pedal to the metal, push your toes into the ground. Inversion and eversion. Imagine trying to roll your foot so you can flatten out your arch and roll your foot so you can lift your arch up off of the ground. Inversion would be flattening the foot. Eversion would be lifting the arch. Protraction and retraction. Okay, protraction is going to be rolling your shoulders forward, and retraction would be pulling your shoulders back. Elevation would be shoulder shrugs, pull the shoulders up, like, I don't know. And depression will be pushing the shoulders down. Opposition would be bringing your finger to your pinky. Remember, we have an opposable thumb, so opposable thumb is doing opposition. Okay, so our gliding movements, it's going to be one flat bone surface glides or slips about another. So imagine taking two wooden blocks and sliding them about one another. Okay, the best examples, like we said, these are intercarpal and intertarsal joints. Another one we get is our vertebra. With our angular movements, these are going to allow us to move about the sagittal plane, okay, or the frontal plane. We will get flexion or extension or hyperextension. And then we can get AB, AD, and circumduction, okay? With our rotation, like I said, your head turning on its axis, the atlas turning on the axis. So you remember, the axis is going to be C2. The atlas is going to be C1. The axis is going to act like the C2, your axis will have the little dents. It'll have that little pointy projection sticking up that will act as a guide so your head can rotate. Okay, special movements, we said supination, pronation, okay, hand up, supination, palm down, pronation. Dorsiflexion, lift the foot off the ground, plantar flexion, go on your tippy toes. Inversion, flatten out your arch. Eversion, lift the arch up. Protract, roll your shoulders forward. Retract, roll those shoulders backwards. Okay. Elevation, shoulder shrug. Depression, put those shoulders down. And opposable, that's going to be using your opposable joint. So here's going to be our 6 different joint types. This is a nice picture of them here. If you look, the order that I have these in, it's like the same positioning they have these in is the same positioning they are on this slide. So let's say ball and socket joint. It's multi-axial and it's freely movable. So multi-axial, it can move in a lot of directions and it's freely movable. Next we'll go to our condyloid joint. Condyloid joints will be biaxial. They can move in 2 directions, and typically you're going to have an oval surface with a flat surface. So here's our oval surface, here's our flat surface. Next we'll go to our gliding joint. So our gliding joint is going to be 2 flat surfaces sliding about one another. These ones are typically non-axial, alright, and they'll allow certain movements. Okay, our next one's a hinge joint. When I think hinge joint, I think elbow. They're going to be uniaxial. They'll go along a single plane. So like your elbow, it's like a hinge. It's like a door hinge. It just lets the door open and close, open and close. Okay, pivot joint. Pivot joint, sorry, I went the wrong way. Pivot joint is going to be rounded and it will be uniaxial. Okay, so a good example here is rotation with the head. So here it shows something like going around in a circle. And then our last one is going to be a saddle joint. Do you see how this kind of looks like a saddle and this looks like a saddle? So it's going to be a saddle joint. So with the saddle joint, it allows a lot of motion, and it's going to let you move in 2 different directions. Okay, so our knee. Your knee is a very large, complex joint. There are some orthopedists that are so specialized, they specialize in just doing knees. They'll usually do other body parts too, but like some of them are, that is my specialty, that's all I deal with, I could do all my research on it. I myself, I am very interested in knees, and I like working with people with knee problems. Knees have so many joints and they have so much force going through them that there is a lot of issues that can occur there. They're going to be biaxial, they're going to allow the teeniest bit of rotation, and they're going to allow free flexion and extension. Okay, your knee is going to be made up of 3 joints. There's going to be the femoral patella joint, so that's going to be where the patella, your kneecap, meets up with your femur. And then there's going to be a lateral and medial tibiofemoral joint. So your medial tibiofemoral joint will be larger. That's going to be where the medial condyle of the femur will meet up with the tibia, and the lateral condyle is slightly smaller. So the lateral condyle will meet up with the tibia here. On here, we're going to have our articular cartilage, okay? On here we'll have we'll have our articular cartilage here. All right, so that'll be our joint cartilage. So that's for the medial side. That's the lateral side. Then we'll have our menisci. Your meniscus, medial meniscus and lateral meniscus. The meniscus is going to be a shock absorber. So the meniscus is this C-shaped thing, and it is there to act as a pad because you are constantly slamming and walking. Each time you take a step, you're going boom, boom. I'm hitting my fist against my hand right now. It's going boom, boom, boom. Every time you take a step, you jump, you do anything, your femur is slamming into your tibia and it is beating the heck out of it. So we have a nice strong cushion there that's made to last 100 years if you properly take care of it. Within your knee joint, there are going to be at least 12 bursae associated with it, and those bursae are going to be there because look at all these, let's go back, look at all these muscles and tendons and ligaments and stabilizing, this thing keeps on going on me, I'm sorry, and all these stabilizing structures that pass over this joint. So we're going to want sheaths and bursae between these guys here so they are not going to rub against each other and break each other down. All right. Your capsule is going to be reinforced by some muscles. So the major muscles that most people think of are your quadriceps and your hamstrings. Anteriorly, okay, your quadriceps are going to give their lateral and medial patellar retinacula. All right, so here's our medial patellar retinacula. Here's our lateral patellar retinacula. All right, then we get our collateral. We get our tibial collateral. All right. So with our capsular and extracapsular joints, we're going to have all these different guys in here. All right. The ones that most people hear a lot about are going to be your ACL and your PCL, so your anterior cruciate ligament and your posterior cruciate ligament. The function of this anterior cruciate ligament is to prevent the tibia from getting, if I was to stick my hand into the screen right now and try to pull that tibia towards me, that is anterior shear. So if you look at it, if I were to pull the tibia forward, this ACL would prevent that. So it's going to prevent anterior shear. The posterior cruciate ligament does the exact opposite. If I was to try to push that tibia back into the screen, here's the tibia right here, I'm pointing at it, that PCL would prevent it from getting pushed back into the screen. Okay? Here's my lateral collateral ligament. Here's my medial collateral ligament. My lateral collateral ligament would prevent me from taking my femur and pushing it medially, because I would stretch this out if I move my femur medially, and my medial collateral will prevent it from lateral shear. All right, next one's our shoulder. Your shoulder has very little stability as opposed to many other joints in the body, although it has the greatest amount of motion as compared to any other joint in the body. So for us to be able to have the huge amount of motion, we need to sacrifice some stability. So it's going to have some reinforcing joints. All right, there's something called a coracohumeral joint. So this guy is our coracoid process, and it will go from the coracoid process straight into the humerus. That's going to help hold that shoulder in place so it just doesn't fall off of your body. There's going to be some glenohumeral ligaments, and those are going to go across the front of your shoulder, and those will prevent, if somebody was to try to push your shoulder forward or push you from behind, those will help protect it there. All right, we have reinforcing ligaments of muscles. Those will be our rotator cuff muscles, are the important ones. The way I remember them is sits. Of course, I didn't put them in order on this lecture. I probably should have. But I go supraspinatus, infraspinatus, teres minor, and then your subscapularis. So sits, S-I-T-S. Supraspinatus, infraspinatus, teres minor, and subscapularis. It's an easy way to remember those guys. All right, next one's our elbow. So it's going to be where your radius meets up with your ulna. This is going to be a hinge joint, so this is going to only move in one direction. So this is going to be easier for us to stabilize. It's going to only do flexion and extension, and there's going to be these annular ligaments. So they will wrap around in a circular type of pattern. All right. Another one we're going to have is our collateral. So we get a ulnar collateral ligament, which goes from the ulna into the lateral epicondyle, and then we get a radial collateral ligament, which is going to go into the same place. All right. Next one is our hip. This is a ball and socket. All right. Do you see how your hip fits into your pelvis much better than your shoulder does? Like there's a deeper capsule here for your hip to go into. So this is going to have a little bit more stability than the shoulder. It'll still allow a good amount of range of motion, but it'll have that deeper socket, so you have more protection and you can have all the forces being transmitted from your lower extremity up into your body. There's going to be this thing called an acetabular labrum. It's going to be underneath of here and on top. Okay? It's going to be in here. It is going to be there to help hold this in place, and it's just going to be a little bit increase instability for that joint. Alright, next one is our temporomandibular joint. Everybody put your hands on your face like Macaulay Culkin in Home Alone where he goes, ah! Put your hands on your face and open your mouth and close your mouth. What you're feeling there is the motion of your temporal mandibular joint. So that's where your temporal bone and your mandible come in contact with each other. Alright? There's going to be two types of motions here. There's going to be a hinge and there's going to be a gliding. So when you grind your teeth, you're gliding side to side. When you open your mouth and you talk, like you guys hear me yap, 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 I'm using hinge movement of that joint at this moment. Okay, so with our joint injuries, we could get sprains, we could get strains, we could get cartilaginous tears or dislocations or luxations. Sprains are going to be if you overstretch a ligament. A strain will be when you overstretch a tendon. ST, T is for tendon. So strain is tendons, sprains are ligaments. So ligaments, these guys, they can tear, but a problem with them is that they heal very slowly because they don't have a good blood supply. Cartilaginous tears, all right, the cartilage doesn't really typically repair itself very well. It can, but it very, very rarely will. The only way to really fix this and properly fix this is with arthroscopic surgery, where we put in some new cartilage, or we take it and recover it from another area, or we put in something else. And then dislocations. If you dislocate your joint, all right, mostly when you think of a dislocation, you think of a dislocated finger, correct? Like you pull your finger out and it's just like facing a funny way, and you just pull it out and it pops right back into place. Here's a torn meniscus right in here. Just a fun picture. Right? Inflammatory diseases, you could get bursitis. So you remember we had those bursa that were between the tendons and the ligaments, and they were there to decrease the amount of friction. Well, sometimes those bursa could get injured and they can inflame. And if those are inflaming, you have two rough ropes rubbing on it constantly. That is going to be very painful, and it's not going to feel very well. These guys, the best thing for them is rest it and ice it and take some anti-inflammatories. Sometimes these can be slow to heal because you use them constantly in everything you do. Tendinitis would be the tendons themselves are going to be agitated. Why? Maybe the tendon sheath or the bursa that's supposed to be protecting them is breaking down or not doing its job. Okay, so with arthritis, there are tons of arthritis. So think of arthrosis, arthrosis, so arthrotic, that's going to be a joint. Itis is inflammation, so inflammation of the joint. These are they can be inflammatory or they can be degenerative. So if you have degeneration, that means the joint itself is breaking down or is aging rapidly. Or if you have inflammation, that means there's just an injury there. It can be acute or it can be chronic. Acute, you usually don't hear much of an acute arthritis. An acute arthritis would typically be caused by a bacterial infection, and you're going to need some sort of antibiotic treatment. Most of the arthritises we hear of are going to be chronic in nature. The most common ones, osteoarthritis and rheumatoid arthritis and gouty arthritis. when you hear of degenerative joint disease, or DJD, that is our osteoarthritis. That's the big one that most people hear of. Okay, like we said, this is very common. It is irreversible. It is best if you catch it in its early phases, because if you catch it in its early phases, you can help slow it down. You can't stop it completely, but you can help slow it down. Most Americans have some sort of osteoarthritis, and it can start, this stuff can start in early age. The best thing to protect your body against osteoarthritis is by being active and just doing normal activities. Okay, it is normal, it is related to aging, but it's kind of that whole use it or lose it thing. If you're not using the joints, that sponge that I spoke about earlier with all the oil in it and the layer of saran wrap over it, that sponge starts to dry out and it starts to become pokey and hard, and it pokes holes in the saran wrap, and now we have an injury. So what's the body's solution to it? It can't make new cartilage, so it's going to make bone, and then it's just going to be painful because it's going to be a rough surface rubbing on something that's highly innervated. So cartilage is destroyed and it's not being replaced. All right, you start exposing the ends of the bones and you get bone spurs, and then the bone spurs can restrict movement and they can start damaging the other side of the bone. So what's the best thing for it? NSAIDs, anti-inflammatory type stuff. Try to get active. Glucosamine and chondroitin, I've seen both ways with this. Okay, some places are saying it's good, some places are saying it's bad. I think that glucosamine and chondroitin are a useful thing, and they should be at least attempted. Okay, next one is rheumatoid arthritis. Rheumatoid arthritis is an inflammatory arthritis, and it is an autoimmune disease. What I mean by an autoimmune disease is your immune system is actually attacking the joint surface. When you were, at some point, your body stopped recognizing the joint surfaces, and it says, hey, these don't belong here. So what happens? It sends in the immune system and it attacks it. It's usually going to happen between the ages of 40 and 50, and it's much more common in women. What's going to happen with it, like I said, immune system goes in and it attacks the surface of the joint. So let's go back some slides. Let's look at a joint surface here. So your immune system could come in and attack this joint surface here. It's going to break down the synovial membrane, okay, and it's going to break down the hyaline cartilage, and you're going to start getting bone spurs forming there because you're breaking down the other stuff and it can't form the cartilage quick enough. So it can be very, very painful. Conservative treatment for it would be anti-inflammatories and physical therapy. There's some new stuff coming out where there's immunosuppressants, so that will stop your immune response. So your body's not going to attack those joints anymore, but at the same time, now all of a sudden you don't have as strong of an immune system, so you could be more likely to get sick. Here's an example of an x-ray of somebody with rheumatoid arthritis. So if you've ever seen somebody and their fingers look completely deformed and all bent in crazy directions, that would be an advanced stage of rheumatoid arthritis such as this. Okay, other arthritis. Lyme disease. So if anybody ever gets bit by a tick and they contract Lyme disease, over time this bacteria can get into your joints and it can cause issues. Another one is gouty arthritis. So people who are dehydrated in general, eat lots of red meat, what happens is they get a buildup of uric acid in their blood, and that uric acid can crystallize and harden at joint surfaces. When I think of this, I think of like a 40 to 40-some year old male that works outside and is a laborer. He's going to eat bacon for breakfast, he's going to eat a hamburger for lunch, and he's going to eat some sort of steak and potato for dinner. And he's going to have 6 to 12 beers at night. He's not going to drink any water, he's going to have some coffee in the morning, and he's going to have soda at lunch. So what's happening here? He's not getting water into his diet, and he's getting dehydrated. He's drinking alcohol, that's going to dehydrate him more, and it's going to cause generalized inflammation. And then on top of it, he's eating all this red meat. The more red meat you eat, the higher your uric acid levels go. Why do I say he works outside? Because this stuff usually happens in the distal extremities, like in your big toes. So the reason for working outside is that they're outside, they have high levels of uric acid, and it's cold out now. Okay? What happens when you make Kool-Aid? You put a lot of sugar in it, you mix it up. It's good, right? I take that Kool-Aid now and I put it in the fridge. The sugar comes out of solution. Same thing happens to this uric acid. So these guys are outside, they're working, it's cold out, they have a ton of uric acid in their system, and their feet get cold. The uric acid comes out of solution and it builds up in their joints. When it builds up in the joints, you get an inflammatory response, and it causes a lot of discomfort. So one of the easy ways to treat it: increase water, avoid alcohol, decrease red meats. And that's it for today.